As Mark said, I'm a surgeon, and surgeons generally are fairly straightforward individuals, and they don't come up with world-beating ideas by and large. But what I want to share with you today, and I appreciate that you and the audience may not have a specific interest in this quite rare area, it nonetheless shows that with a bit of forethought and a bit of planning, you can actually make an enormous difference to outcome. So what I want to talk about is this technique of what's called cytoreductive surgery and heated intraperitoneal chemotherapy. We set this unit up specifically to treat a certain specific type of condition back in 2002. And really the sort of conditions that we were looking at, they're all rare, these, with the exception of the last one. And that's what I'm going to concentrate on this morning, really, in terms of talking to you. There are rare conditions that affect the appendix which cause these peculiar situations whereby patients get a lot of disease inside their abdomen, which is very difficult to treat. And there's a specific way of dealing with it. But peritoneal metastases of colorectal origin, however, are not rare. In fact, if you think about bowel cancer and you think about where it metastasizes to, most people will immediately think of metastases to the liver and to the lung. But in actual fact, the area called the peritoneum, which is essentially the wallpaper that lives inside the abdomen, is nearly as common in terms of recurrence and disease treatment failure. It looks a bit like this. You can't really see these desperately easily, but this is a photograph of a patient we operated on. To orientate you, her head is up here and her feet are down here. The stomach is there, and there's a structure hanging off it, for those of you who aren't medically inclined, called the omentum. And you can see there's a nodule of white material. That's a metastasis. There's another one there. When we then look up into the sort of attic, if you like, of the abdomen, underneath the diaphragm, you can see similar white spots sitting on the diaphragm. And these are classical peritoneal metastases, which really have a pretty bad reputation. This is data from Eindhoven that goes up to 2008 and then has had subsequent quite long-term follow-up. And if you look at the black line, this is what happens to patients who have peritoneal metastases if you don't do this cytoreductive surgery with heated intraperitoneal chemotherapy. This is with best adjuvant care in terms of systemic chemotherapy. So you can see it has a pretty horrendous outcome, with pretty much everybody dying of the disease by about 3.5 years. So it is a lethal condition. So is there an alternative? Well, the alternative is this, and this is what we specialize in. The technique is called cytoreduction and heated intraperitoneal chemotherapy, or what we call HIPEC, and it actually has got nice guidance, which was issued back in 2010, and to be fair, probably requires revision. Now, what is it? Essentially, what you do is you operate on the patient and you remove everything that looks abnormal, and I mean everything. You don't just leave a little spot because it's difficult to get at or because it's on an organ you don't want to damage. You have to remove everything. And that includes stripping out the lining of the abdomen where it's involved. We resect areas that have got abnormal tumours in them or abnormal areas in them, which includes bowel resections, liver resections, sometimes resection of the bladder, often a resection of the abdominal wall. Anything that we can't resect, we will then destroy using diathermy, which is high-powered electrical current, to ablate it. And then also, in addition to that, there are certain areas that are prone to developing disease, even though they may not have done at the time of operation. So a common example of that is in a woman with bowel cancer, they may not have ovarian metastases at the time of diagnosis, but it's a very high-risk area, and so commonly we'll remove a woman's ovaries in this situation. So basically, you remove everything, and you remove everything that's at risk. You then follow it up with this rather unusual treatment, a surgeon giving chemotherapy. So during the operation, at the time of this resection, we set up a system whereby we can perfuse the abdomen and pelvis with heated chemotherapy solution. And the whole point of this is it's got three actions. First of all, there's obviously the chemotherapy, which kills viable cells. The heat itself will kill cells, and we heat people up to about 42 degrees centigrade. If you want to know how warm that is, that's about the temperature of a nice warm bath. If you go 43 degrees centigrade, you cook the patient. If you go below 41, 40.5, it doesn't work. So it's a very narrow band of temperature. The third thing it does is that the fluid is circulated and filtered, so any cells that are there hopefully will be removed at the same time. And we use a combination of chemotherapies. More often than not, we use mitomycin C, and that goes on for an hour and a half. But more recently, we've started using a combination of intravenous chemotherapy, 5-FU, and oxaliplatin intraperitoneally. So we set up this perfusion circuit, which is essentially a very simple piece of plumbing. You have the patient with some pipes going into them that takes the fluid in from a pump that's specifically designed to move it around to heat it up, and then it circulates around the abdomen and then drains back out again. We have a total of 4 separate temperature probes in the abdomen, and then temperature probes on the inlet and the outlet tubes, and we also measure the patient's core temperature. We're very, very careful about the temperature control, and it's actually an extremely important part of it. And this is what it looks like in theatre. So we have a specific team of perfusionists, and Mark is very helpful in terms of providing the drugs in the correct dosages. And now we use a custom-made piece of kit that's made in Italy. We have 3 of these machines. They come in at around about £75,000 each. And there's not a big second-hand market for these machines, so you can imagine we have to have them built, basically. And essentially what happens is that the patient has the so-called Colosseum set up, because Paul Sugarbaker from Washington, in his rather cute American way, thinks that looks like the Colosseum in Rome. I've been to the Colosseum in Rome, and it doesn't look like that. But you kind of get the drift. You create a basin that you can then put fluid into. And the blue lines you can see here are the temperature probes. And the temperature is mapped out extremely carefully to make sure that that's kept within the therapeutic band. So how many have we done? As I said, we started in 2002. For all conditions now, we've nearly cracked the 1,000 mark, and we would assume that by the end of this calendar year we will have done that. The majority of tumours that are having this treatment is this red group here, which are the appendiceal tumours that are benign, a condition called pseudomyxoma peritonei, which is actually very rare, but because we're one of 2 centres in the country, we get everybody. So we're able to accumulate quite a large number of them. The group that I'm really referring to here is this lot, the PMCRs. This is the purple group, of which we've now done just over 200. And what's interesting is the changing referral pattern, if you like, of this condition. So we started essentially in 2002. I know there's some numbers there from 1999. These are the colorectal cancers. This is the group I'm talking about. And this is the other group, the appendix tumours. And what you'll see, this is actually the very rare group. And we've been operating on these really since the turn of the noughties. And you'll see that the reds are the referrals and the yellows are the numbers that we've done. 2016, our year starts in April. So the 2016 numbers, that represents 6 months. So it's half a year, okay? And what you can see is, with the eye of faith, is that we've more or less got now the referral practice and the operation rate on this rare group stabilised. And the other centre down in Basingstoke have seen very much the same thing. Interestingly, however, if you look at the bowel cancer group, you'll see that we really didn't do very many up until around about 2011, 2012, and you can see what's happening to the referrals. Now, this is only half a year, and you can see that by the end of the 12 months, it's going to be up here. Now, the reason for that is because the NHS has now woken up to this, and they've accepted the fact that there needs to be a referral pattern for this in England. If you're Welsh, you're stuffed. The Welsh government will not pay for this, and we've had a lot of trouble with that recently. But it's becoming an ever-burgeoning group of individuals. Numbers, these are the appendix cancers. Don't really want to spend too much time on them other than say that we do them. We measure the amount of disease that's present within the abdomen, because this so-called PCI score is the peritoneal cancer index. And basically we use a very simple grid here, which you add up. You can get a total of 3 For each part of the grid, there are 13 individual squares, so the total score you can get if you've got disease everywhere to the maximum extent is 39. And a score of 39 is pretty bad, quite frankly. And it's a very useful predictive score. The lower your PCI index, the better you will do, essentially. And if you look at the colorectal cancer group, we've had a pretty broad range. We've had people who don't have any disease, and we do a truly prophylactic procedure, right up to people who have got disease everywhere. And the median score is about 8.5. We think in this group, if you've got a PCI score of more than about 13 or 14, you're probably not going to have a curative procedure. Then we score people on how well we've done. And we give this score called a cytoreduction score, and essentially you want to be able to say you've removed everything, because that's the one you want to be. That's where you want to be. But we also have this separate group called a CC1, which we've actually left little tiny bits of disease, but they're no bigger than about 2.5 millimeters in size, and we reckon that's big enough to be got at by the chemotherapy. So if you think of the CC0s, no disease at all, and the CC1s in the colorectal cancer group, which is this lot here, you can see that's the yellow and the red. So the 3/4 of the patient that we're doing this to, we're getting a complete removal of disease. People have a bit of a view on this operation that it takes hours, it's got huge morbidity attached to it, they need gallons of blood giving to them. Well, that's not true if you do it in a controlled manner. This is our blood transfusions given to patients during admission. Okay, this isn't just during surgery, this is during their time in hospital. And you can see that the vast majority don't receive any blood at all in our hands, and there are very few people who end up having 2 units of blood. You can see that the operation time in our hands, the median is 8.5 hours, goes up to 12 hours. I get bored at around about 12 hours, and really you're probably not doing the patients any favours by doing it any longer than that. And the median length of stay in our hands is 12 days, and that is the shortest length of stay in any of the international literature. Does that mean then we're throwing people out too early and they're having horrendous times with complications? Well, we monitor all of this, and this is data that goes up to August 31st this year from 2002. This is a total of 907 patients, so the red is the 907, the black is just the 200 patients of the colorectal cancer group, which are a more morbid group because they've got established metastatic cancer. Our 30-day mortality, in other words, patients dying within 30 days of their operation, we've had 1 out of 201. And our total group of over 900 patients, it's 0.4%. So we're not killing a lot of people. We grade people on their degree of complication, so a G3, G4 complication is a serious complication. It means return to theatre, it means significant illness as far as the patient is concerned, and our rate in the colorectal cancer group is just under 16%. The whole group at 6.5%. Now these are quite an ill group of patients before you start. There's a study from France that's done a very similar thing, and their G3, G4 rate is about 30%. So we're about half that. If you look at minor complications, yes, about 1/4 of people will get a minor complication, wound infection, chest infection, etc. Interestingly, as far as the chemotherapy is concerned, it doesn't give any specific complications that we've really identified. So what happens to the patients? You remember that graph I showed you to begin with from Eindhoven, where all the patients were dead within 4 years. This is now reasonable numbers. We're going out to 5 years. The blue line are the group of people who have had that treatment. So about 50% of people are living 5 years, as opposed to nobody living in 36, 40 months. It is a quantum shift. Admittedly, if you don't get a full cytoreduction, you're looking at a very similar profile to what you had before. When you look at other groups, the appendix cancers, they do, interestingly, slightly worse, actually, over time, although they are a less morbid group of people. They've got a nastier condition, actually. And if you look at the group that's the PMP group, actually this does a fantastic job to them. About 85% become long-term survivors. We had a patient experience day yesterday where we invited a whole load of survivors to come to us, and about 100 patients came to see us. And I was meeting people that we'd operated on 12 years ago and they were absolutely fine. And this is a group of people that if you don't do this to, they're all dead within 2 years. So this treatment works. There's absolutely no question about it. So in conclusion, it certainly improves outcomes for people with a really nasty condition, but it is a very significant procedure and needs to be done within a very controlled environment. And actually it's an indication of how far-sighted the NHS has been in controlling this to the point where there's only 2 units that do this in the country that's been able to expand on its experience. Thanks very much for your attention.
Thank you very much, Malcolm. That was really interesting. We've probably got time for one question. I mean, Malcolm, can I ask you? Obviously there's so many referrals now, and there probably will be other centres opening for the colorectal cancer. What do you think the learning curve is there? How quickly will these surgeons become good at it?
Well, I started in 2002, and I'm still learning now. I think it's fair to say, and I've probably myself have done over 550 of these cases. There's some research that's been done by a European group that reckons that you need to do at least 100 as a unit to get over the initial setup problems. But we're currently trying to persuade NHS England to look at opening up 2 other centres. There's a desperate need for one down here in London, and there probably needs to be another one in the east or the north east.
Mentoring, no doubt. With good mentoring.
Yeah, we would aim to be one of the index groups that would help set those up.
Yeah, great. Thank you very much.